Motor neuron disease is a neurodegenerative disorder of unknown etiology. Progressive motor weakness and bulbar dysfunction leads to premature death, usually from respiratory failure. Due to the complexities of the disease, there are a number of differential diagnoses, manifesting itself as pure lower motor neuron disease, pure upper motor neuron disease, and amyotrophic lateral sclerosis. The etiology of motor neuron disease is unknown. However, recent lines of evidence support genetic factors in familiar motor neuron disease, such as dysfunction of the enzyme superoxide dismutase on chromosome 19, excitotoxins such as glutamate, poor autoimmune processes, and accelerated neuronal degeneration. Motor neuron disease is a progressive degenerative disorder affecting the specialist nerve cells called motor neurons that control muscle movement. Motor neurons are vital in controlling the various activities of the body that involve muscle movement, including walking, running. As the disease progresses, these actions become more difficult and eventually the patient is unable to carry them out at all. The skeletal musculature responsible for these movements are innervated by a group of nerves called the lower motor neurons, found in the ventral horn of the spinal cord. In motor neuron disease, damage to the ventral horns of the spinal cord leads to atrophy or wasting of the ventral roots. Neurons in the frontal and temporal lobes also degenerate. Studies looking at the nerve damage caused by motor neuron disease have revealed a sponge-like deformities called spongosis, scheme-like inclusions, and Boonie bodies, as well as the formation of vacuoles. Mann, in his study of deceased patients who have been previously diagnosed with motor neuron disease, found a number of molecular changes in patients who showed a sharp decrease in the molecular weight of RNA, transferrin messenger proteins. But the abnormalities are more striking in the anterior horn cells of the spinal cord, showing a large amount of shrinking or atrophy. Mann concluded that the nuclear DNA is probably inactivated with a consequent reduction in the synthesis of messenger RNA, and that following molecular shrinkage and progressive loss of cytoplasmic RNA leading to cell death. Reich and Goldberg then hypothesized that this was caused by the neurotoxic effects of actomycin D, which is known to inhibit the synthesis of DNA and directed messenger RNA. Figure 1 shows the consequent progression into motor neuron disease, starting with the possible motor neuron susceptibility factors, including an altered immune response to injury or variations in neurofilament function, and then an unknown insulate, which could be a virus, a somatic mutation, or an environmental toxin, and eventually into motor neuron injury, which can be caused by glutamate toxicity, caspase activation, and neurofilament disorganization, as well as mitochondrial dysfunction. And this then causes cell death. Symptoms of motor neuron disease are usually noticed during the onset of the disease in the arms, legs, hands, and swallowing muscles, also known as the bulbar musculature. Muscle weakness and atrophy then usually occur in both sides of the body. Individuals will then lose strength and the ability to move their arms and legs, and in the later stages, the ability to hold their body upright. Bulbar weakness can cause speech slurring in the later stages of the disease. In the latter stages of the onset of the disease, the failure to function of the diaphragm and chest wall will cause the inability to breathe without the use of a mechanical aid, usually occurring between 3 to 5 years after the first onset of symptoms, ultimately causing mortality from respiratory failure. Due to the degradation and eventual cell death of the mitochondria in the skeletal musculature, a number of key functions are impaired or cease to function in patients with motor neuron disease. In walking, atrophy, either minor or severe, in the distal and proximal limb muscles can cause a number of conditions that affect movement control. These include lower motor neurons associated with weakness can suffer from atrophy, weakness, hyperreflexia, and leg cramps due to the degeneration of anterior horn cells. In the upper motor neurons, degeneration of large pyramidal cells can cause spasticity, which is a feature of altered skeletal muscle performance with a combination of paralysis, including increased tendon reflex, hypotonia, which is the impaired ability for motor neurons to regulate descending pathways and gives rise to disordered spinal reflexes and synaptic inhibition. In those without the presence of motor neuron disease, breathing is carried out autosomatically, requiring no conscious control. However, for those with motor neuron disease, the body sends a signal to stop the movement of the lungs and surrounding tissue to allow for the proper processes to occur. There is no cure or standard treatments for motor neuron disease. However, symptomatic and supportive treatment can help people be more comfortable while maintaining their quality of life. The drug riluzole is the only prescribed drug by the FDA, and it prolongs life by 2 to 3 months, but does not relieve symptoms. However, it does reduce the production of the neurotransmitter glutamate, responsible for providing signals to the motor neurons, as it is believed that too much glutamate may harm motor neurons and inhibit nerve signaling. Whilst there is no cure, a number of drugs can be used to treat symptoms of motor neuron disease. Muscle relaxants may be used to help reduce spasticity. The use of botulinum toxin may be used to treat jaw spasms and drooling. Anticonvulsants may help to reduce pains in symptomatic patients. And the use of benzodiazepines for pain treatment and muscle relaxants may help to cease symptoms in individuals. Physical therapy, occupational therapy, and rehabilitation may help to improve posture, prevent joint immobility, and slow muscle weakness and atrophy. Stretching and strengthening exercises may help reduce spasticity, increase range of motion, and keep circulation flowing. Some individuals require additional therapy for speech, chewing, and swallowing difficulties. Applying heat may relieve muscle pain. Assistive devices such as supports or braces, orthotics, speech synthesizers, and wheelchairs may help some people retain independence. Current clinical exercise prescription is predominantly individualized rehabilitation that may or may not include strengthening or aerobic exercise prescription. Continued lack of robust evidence regarding the efficacy and benefits of exercise people with MND may influence the availability and quality of services provided for this group. Exercise, when prescribed appropriately, may be physically and psychologically important for people with motor neuron disease, especially in the early stage of the disease and before significant muscular atrophy or deconditioning occurs. Although exercise may not improve the strength of the muscles already weakened by motor neuron disease, strengthening exercises with low to moderate weights and aerobic exercises such as swimming, walking, and bicycling at submaximal levels may be important components of an overall management plan. The degree to which this safe range narrows is dependent on the extent of the disease involvement and the rate of disease progression. A weak or denervated muscle is more susceptible to overwork damage because it is already functioning close to its maximal limits. Activities of daily living alone may provide a training stimulus to weak muscles, and additional exercises that would help strengthen healthy muscles may actually cause overwork damage. Reduced physical activity, particularly if prolonged, reduces function of the neuromuscular system, in addition to skeletal and other organ systems. Strength lost through inactivity and disuse can significantly debilitate individuals with motor neuron disease, making them highly susceptible to cardiovascular deconditioning and muscle and joint tightness, leading to contractures and pain. Some neurologists worry that regular exercise could speed up the progression of the disease by turning up the production rate of reactive oxygen species, potentially damaging weakening muscles and increasing inflammation of the connecting nerves. Exercise, either on a cycle ergometer or a treadmill ramped up to 60 to 65% of oxygen output for about 10 to 20 minutes, sufficient intensity to keep weakening muscles moving but not overworking or damaging them. Workouts are typically scheduled 3 times per week. The efficacy of strength training exercises is still up for debate, and therefore the literature on anaerobic strength training exercise is limited. Due to the wide variety of causes, symptoms, and types of motor neuron disease, the current literature as to the dose-response relationship varies, and therefore a one-size-fits-all approach is and never will be possible. Individualization of programs is paramount in order to gain the appropriate metabolic responses needed in order for the therapeutic effects of exercise to be seen, and for the quality of life improvements all motor neuron disease patients are seeking to be attained. Thank you.